Hello, everyone. My name's Emily Gaddam. I'm a nurse infection preventionist and a specialist in health delivery science. Welcome back to my channel. I sound ridiculous saying that, but here we are. And this is a quality chat. Today, I want to look at hospital-onset bacteremia, a new potential measure by National Health and Safety Network, and we are going to look at a recent article published in the American Journal of Infection Control, AJIC. So here's the article. It was published this year, June 7th, and it's titled Etiology and Utility of Hospital-Onset Bacteremia as a Safety Metric for Targeted Harm Reduction. Hospital-acquired infections, or HAIs, are a major driver of morbidity, mortality, and they cost health systems and the U.S. billions of dollars each year. Currently, we use central line-associated bloodstream infections, or CLABSIs, to surveil for these hospital-acquired infections, but these require intensive surveillance and review. All-cause hospital-onset bacteremia, or HOB, or maybe it'll be called HOB. I don't know. If you know, let me know. But it might be a simpler reporting metric. It correlates with CLABSI and is viewed positively by some hospital-acquired infection experts. The proportion, however, of these HOBs that are preventable is still unknown. So the authors of this retrospective case review reviewed all of their HOB cases in 2019. The authors are from an academic tertiary care hospital, and the information they collected included provider-perceived etiology of the bloodstream infection, clinical factors, microbiology information, severity, mortality, and management, or how the patient was managed. And then from there, they made a decision as to whether the HOB was preventable or whether it was perceived as not preventable based on all this information. And of their 392 instances of hospital-onset bacteremia, 56% of these, or over half, were determined to not be preventable. 44%, on the other hand, were preventable, and of this 44%, about 10% of these were CLABSIs. Not preventable sources included gastrointestinal and abdominal sources, neutropenic translocation, and endocarditis. Patients with HOB were medically complex patients with an average Charlson comorbidity index of 4.97. They had a higher length of stay, 29.23 days versus 7.56 days, which I don't think is surprising. And they also had a higher inpatient mortality. The odds ratio was 8 times that of patients without hospital-onset bacteremia. So the conclusion is that the majority of their HOBs were not preventable. This would make it a less actionable target for quality improvement than what we currently have with CLABSIs or CAUTIs. And standardization across patient mix would be even more important if we are going to use HOB as a metric, and particularly if it becomes linked to reimbursement, because large tertiary care centers with sicker patients are going to have more HOBs and could be penalized unfairly. So hospital-acquired infections cost the U.S. billions of dollars annually. Looking at the article, what they cited, I believe, was $28.4 billion. So it's a lot of money. It's understandable why we would want to prevent even more infections than what we are preventing currently. But both CLABSI and HOB as a measure has its pros and cons. Some of the pros of CLABSIs is it's what we're currently using, and it is very targeted to something that we can make a difference in, which is central line infections. The downside of CLABSI is that it requires very intensive surveillance and chart review, manual chart review, and it may be taking some of our attention away from other potentially preventable infections. On the other hand, HOB is a much more standardized and possibly simpler way to be able to report data to National Health and Safety Network. It can be implemented on a very wide scale, and it will be standardized across all centers. However, as the study highlights, without very intensive risk adjustment, if CMS starts using this as a quality measure, it may not truly indicate the quality as much as it's indicating how sick patients are. And it's also, if over half of the HOB are deemed not preventable, it makes it a measure, but not necessarily a measure of quality. So I feel like I need a drum roll for this last slide. I do not have a drum, so I'm going to do it on my laptop. So further research is needed to assess the utility of HOB as a measure of quality and if it can be made into something that is actionable and useful in terms of reducing harm to patients. I am very low down on the totem pole, so I do not know what people are talking about in regards to this measure, when it may be implemented, and what the impact of that will be. But I would love to hear what everyone has to say about this and what insights you might have. So I'm looking forward to hearing from you and what everybody is thinking about this. Thank you.